Good afternoon. I'd like to begin with some notes of appreciation. First, I thank the Friends of NIDA for sponsoring this. I'm especially appreciative of NIDA for not only funding our research, which we'll hear more about in a minute, but for funding the cutting-edge research in our area of prevention science. Because it is that which suggests the potential for primary prevention in addressing this issue. And I want to thank you, kind of apropos what Rico just mentioned, for taking the time out of your busy days, hanging in there with us over lunch after you've eaten. Please feel free to stretch a little bit, whatever you need to do, to bear with us, because we are inundating you with information. But I hope it's information that will serve you very well. For that end, I want to begin with the end, in a sense. So I'm just going to say briefly what I hope the take-home message is for you when I get to the end of this talk. And the first kind of recaps what you've already heard, and that is that the science suggests that there's tremendous unmet, unrealized potential of primary prevention in addressing this problem. Second, based on the science, as Rico nicely indicated or suggested in that slide that he just showed about the spending, more investment is warranted. Based on the science, more investment is warranted. If you've already gotten some evidence of the third take-home, which is that if the investment is made, it is reasonable to expect a good return. I'll say more about that as well. Last take-home is the accumulated prevention science over the past 20 years provides direction, suggests some next steps. I'll give some concrete ones at the end of this talk. So I'm going to do that. I'm going to split this out into 3 segments. The first is basically about the why. Why think about primary prevention? Why think about how this might help us with this opioid epidemic, this crisis we face? And there I'll talk primarily just snapshot level of the evidence on reduced prescription drug misuse and economic benefits shown by our research. Second, how. Evidence, I want to share some evidence, as you've heard promised by our first 2 speakers, of how effective community systems are for supporting proven evidence-based prevention can help. And lastly, I want to say where to. What does all of this suggest about where we might go, specifically with respect to this important but daunting task of scaling up community systems and how that connects with prevention workforce development? So why? Simply put, it works. It works. It saves money. Now, for the sake of time and all the information you've already had, I'm just going to give you the most basic nutshelling of research that's been conducted over 20 years, funded by NIDA and some other agencies and foundations. But primarily by NIDA, we've been able to conduct 3 longitudinal randomized controlled trials. And the data that I'm going to show you is data from young adults. So data from people who participated in programs 14 years in some cases after the pre-testing, the baseline period. It's all research that's been conducted with school districts, up to 36 of them in one of our NIDA-funded studies, randomly assigned to 2 different conditions. I'll share a bit about those conditions. And it's about these outcome measures that we've added to evaluate prescription drug misuse. I'm going to focus specifically on those outcomes and just briefly mention how we've addressed how these universal interventions, meaning for general populations, all the eligible families and youth in a community, can help the at-risk youth and families among them comparably well or better. So this is my first snapshot. What do you need to know? Basically, it's a project called Project Family. It focused on a single freestanding family-focused intervention that youth and families received when the youth were in 6th grade. We have two basic measures, two outcomes that I'm presenting here. One is on the non-medical use of prescription drugs in general. One focuses specifically on narcotics. I'm presenting the data from 2 time points. So remember, 6th grade, the kids were about 11.3 years of age on average, through young adulthood, age 21, in one case, age 25. In the other case, you see the blue represents the Strengthening Families Program, specifically the Iowa Strengthening Families Program, and I'll tell you a little bit more about that later. I just want to give you the basics of its impact in this particular case at these time points. So age 21, you see the difference between the percentage that are using non-medically prescription drugs at age 21, and then also at age 25, you see there's around a 10 percentage point difference there. Second snapshot. This is from Prosper. This is from our community prevention systems model that we studied. And this is also young adults, so same thing. They got, not in this case, not just one program, but they were selected a family program, a universal family program for all families in the community, along with a school-based program. And this gives you, in a nutshell again, the results. So the results are statistically significant, but they're also practically significant. To convey what that means, we calculate these relative reduction rates. In this particular case, what it means is that for every 100 misusers, as is stated in bold, in non-prosperous communities, if what we studied held, you would expect that there would be 20 to 26 fewer in prosperous communities on these outcomes. So I want to just, we have lots more slides, including slides that get to the point that Wilson first made about how these interventions not only affect the families that participate, they affect the social networks of youth. Youth, by our study, through our social network analyses, are less influential. Wilson was talking about environmental influences. They're less influential. We've shown that. We have shown essentially, to quote another phrase he used, that they help establish a protective shield whereby the youth who participate in these programs are less likely to take opportunities to use drugs. So those are the outcomes of interest that make the case. Here are some of the results of economic analyses. So one of our colleagues has done a very conservative economic analysis of cost effectiveness of our program. He started by doing an estimate of what it cost our society for youth who use, as indicated by the measures I just showed you, and it's $8,965 by this one economic analysis. To prevent one youth from misusing opioids before 12th grade, he evaluated the cost, what doing these programs cost. At most, he looked at several different combinations of family and school programs. It's less than half of what it would cost society each year. But again, the main point is that these can be cost effective. We have done other analyses on the benefit to cost ratios along the lines Rico mentioned, and they're also cost beneficial. And I'll tell you a little bit more about the two programs that represented the most cost-effective combination. So, why else? I don't need to say much about this. Rico did a very nice job of describing how these programs address what's critically important, the known common risk factors. When you do that well, you don't necessarily need to have content of programs that specifically addresses prescription drug misuse. Common sources are friends, as the data show. When you do these programs, you reach not only the kids who might be currently using prescription drugs, but also friends, people in their social network who might be supplying them. So, and there are two Surgeon General panels, one of which was in 2011 that focused specifically on preventive interventions and recommended that this needs to be part of the strategy. This 6 years ago, and you just saw what has and hasn't happened in that span of time. Again, a call to action, and highlighted by the 2016 Surgeon General report, which highlights how critically important it is to invest more in this kind of prevention. So how? How do you do this? I will focus on community systems that help us deliver in a quality and sustainable way proven prevention programs for all in the community, all families and kids. I'll focus specifically on the ones that we've done that address middle school level kids and youth to start. So the types of programs we've studied, again, target modifiable risk and protective factors in family and school environments. Wilson alluded to skills deficits and their relevance in drug use. One is critically important skill is problem solving. That's among the sets of skills that these programs help youth learn in conjunction, in the case of this program, with their parents. Just to give you, again, a basic sense of this, these are programs that are just 7 weekly 2-hour sessions long. Kids are involved in each session, but with the 2 hours, they first meet among themselves, and the parents meet among themselves, and they're brought together for the 3rd hour. Just to give you a sense of how these programs work. The Life Skills Training Program is a school-based program that has 15 sessions conducted in the classroom setting for time periods that vary, but usually are about half an hour to 40 minutes, and often in the context of something like a health class. I want to give you a bit of an idea. Again, just 2 slides to give you a better sense of what these community systems look like. You'll hear more detail about how it works on the ground in a few minutes. This is the organizational structure. The 3 key things there. 1, this organizational structure is based in existing systems. There are existing infrastructures, the public school system, and in our case, the land grant outreach system that are there in every community in this country. At least there is reach to every community in this country. That's what they're based on. 2, there is a system for sustained, proactive technical assistance to help the community teams do the best possible work they can. And 3, there is a sort of a broader structure that helps support all the effort in the state. This is a slide that a community team leader put together that draws an analogy with a bus. So, in past talks we've done together, this is we have heard people report that this is sort of a good analogy to use. So you have the co-leaders of these community teams, in this case from representative public school system and the university outreach system to the community, driving the bus. The cargo are these evidence-based programs. They're delivered by the representatives of the each of the community segments that has something at stake in preventing these issues. So what do? They plan and coordinate these family programs. They work with schools to implement the school-based programs, and importantly, they learn how to sustain their own efforts on their own. So we just had a 15-year celebration with one of our communities. So they have been sustaining themselves for 15 years, long after they were receiving any outside grant funding. Last segment, importantly, where do we want to go with this? Basically, in a word, we want to spread these proven prevention programs through expanded community systems and workforce development. This highlights the point that we recently made, 2016 Surgeon General report, about the importance of applying these systems. And we're finishing up some work that started about 4 years ago. This is work on a comprehensive universal prevention curriculum for training the workforce, building on the existing people in communities and states around the country so that they can do this more extensively. I don't have a lot of time to describe this in detail. There's plenty available if anyone is interested. This is work that was supported through the U.S. Department of State, working in conjunction with some WHO, the Colombo Plan, UN, other international agencies that basically organize some scientists to develop these trainings, and our institute is responsible for dissemination in this country. We have just begun to outline what we will be proposing to do with this to train the community workforce and spread proven prevention to address this opioid issue. Basic purpose is this workforce development that would expand in a very systematic way, state by state, the number of communities that might show reductions in opioid misuse. There's some basic goals are to develop a prevention scientist steering committee in each state coupled with a national network of prevention workforce development people that are working on these training programs on a multi-year project. It would have these 3 phases, starting with groundwork in 5 states where we do an initial, we find people who are already doing prevention work, provide this training and additional credentialing, and select from among those preventionists who can keep doing the work. That preventionists who become trainers of trainers to expand the workforce and to expand the number of communities. Just beginning stages, we're hoping to do a controlled study of this in up to 22 states, and we're going to look at, like we always do, when we're doing this kind of controlled study, the process of sustainability and scale-up and what seems to be working to put in place the mechanisms for continuing to do that. Conclusions and implications. First, again, going back to that take-home message, the pattern of long-term positive findings across 3 controlled studies up to 14 years past baseline over the last 20-plus years suggests this unmet potential and suggests the importance of investing more, especially when considered in conjunction with economic analysis. Again, it works to save money. We have findings specifically from prosper, this community-based system for implementing, sustaining those proven interventions on a long-term basis. So overall, primary prevention, we think, has this potential public health impact and economic benefits with those investments, and it could be especially enhanced by systematically, state by state, going about developing the workforce capacity, prevention workforce capacity for developing the system. So to take that one step farther, some recommended next steps along the lines of not just doing the research, not just doing the trainings, but sort of teaching the people who will be doing these in communities around the country to fish so that they can sustain it on their own. 3 basic steps: train the prevention workforce on a state-by-state basis, apply these proven community systems for delivering evidence-based programs, and build into that the leadership for doing more and spreading more, disseminating more within each state. And one example that we're kind of in the beginning stages of developing is prospering communities, which would roughly, we're just beginning to do the budget estimates, would be something like $10 million, but we think it really would result in a big return on investment. Thank you from myself and our staff at the Institute for taking the time to listen to this talk. And here's our website.